into the hip joint. So like knee joint, hip joint is also a weight bearing joint, and it is a ball and socket type of the joint. And it is the synovial joint, and we will discuss the hip joint under the headings of bones taking part, then the fibrous capsule attachment, then the ligaments of the hip joints, and then the movements produced by the muscles, and last is the applied. So any synovial joint we have to discuss under these headings. So a joint of the human body, small or large, or slightly movable or freely movable synovial joint, whenever a joint is labeled as synovial, it should fulfill the 4 prerequisites if it is a synovial joint. Number 1, the bone which are taking part, they should be covered by articular cartilage. They should be smooth. And as this articular cartilage, the hyaline cartilage. Secondly, it should contain synovial membrane, which is a delicate membrane, and the joint should have the synovial fluid in it, secreted by the synovial membrane, which is intracapsular. And joint should be covered by, bones of the joint should be covered by fibrous capsule. So if any human body joint is having these 4 structures together, we label that joint of the human body as the synovial variety, maybe slightly movable or freely movable. So we will take one by one the hip joint. First is the bone. So any joint which comes synovial joint, it will be having these headings. It may be TM joint, it may be small or large joint. The headings of this synovial joint is the same. 5 fingers, 5 headings. Now first the bone which are taking part in the joint formation, first we have to describe the bones. As we know, it is formed by the 2 bones. On one side there is a hip bone, on the other side there is a femur bone. But out of the femur bone, which part is taking the joint formation? That is we have to describe, and which part of the hip bone which forms the joint, that we have to discuss. So on the femur side, the head of the femur, which is the hemispherical, will take part in the joint, plus a small portion of the neck also. And on the hip side, this is the acetabulum. The cup will take part in the joint formation, and acetabulum is the area, cup shape, which is the union of all the 3 bones. So all the 3 bones forming the hip bone, that is the pubic, ilium and ischium, they all meet in the acetabulum. So acetabulum is contributed by all the parts of the 3 bones. So first we will discuss the bone, that is the joint formation. So first bone we will discuss is the head of the femur. So as we know, the head of the femur is hemispherical, round in structure, and it is smooth through touch. Why it is smooth? Because it is covered by the articular cartilage, that is the hyaline cartilage. Except in the center. In the center, the head of the femur is rough and having a pit that is called the fovea capitis. Fovea capitis. And then where the head ends, there starts the neck of the femur. And neck is rough because of the presence of multiple nutrient foraminas. And later to the neck there is a greater trochanter, a large expanded area which is also rough. And medially there is a lesser trochanter. Both the greater and the lesser trochanter, they are joined by anteriorly by a faint line that is called the intertrochanteric line. Intertrochanteric line. And if we see the posterior aspect of the head of the femur, then medially this is lesser trochanter, laterally is the greater trochanter, but posteriorly the greater trochanter is also connected to the lesser trochanter, but not by the line, but a raised area of the bone that is called the trochanteric, intertrochanteric crest. Intertrochanteric crest is a raised area joining the greater trochanter with the lesser. So we have to discuss as well as we have to make the diagrams of the anterior and the posterior part of the how the head of the and neck is built. So this is the intertrochanteric crest from greater trochanter to lesser. So it is a raised area, but anteriorly it is a faint. It is almost indistinct. It's not much raised as compared to the posterior. So it is called the crest, intertrochanteric crest. And this intertrochanteric crest has got features. In its upper medial part, it has got a fossa. This is called the trochanteric fossa, or also called the obturator fossa. And in the middle part, it has got a raised area which is called the quadrate tubercle. Quadrate tubercle. So this is here is the fossa. In the upper medial part of the crest, this is called the trochanteric fossa. And in the middle part of this crest, there is a raised area. This is called the quadrate tubercle that we have done for the insertion of the quadratus femoris muscle, which are also the lateral rotator of the foot. So this is the posterior and the anterior view of the, you have to make the two diagrams, posterior view and the anterior view of the hip joint. Now comes the acetabulum. So head of the femur, it fits into the cup-shaped structure that is called the acetabulum, which is formed by the union of all the three bones, the pubic bone, ischium and the ilium. So all contribute in the formation of the cup-shaped acetabulum. So we will discuss what is the acetabulum. So acetabulum, as we know, it is a cup-shaped structure. And it has got a bony rim, or the bony margin of the, but it is interrupted. It is not circular, but it is interrupted medially. So if we see the cup, so in the medially it is interrupted here. So the cup or rim is not complete. And this gap is called the acetabular notch. It's called the acetabular notch. However, this acetabular notch is closed by a ligament that is called the transverse acetabular ligament. Transverse acetabular ligament. but still there is a gap is already there. So with this structure they go in and out of the acetabulum. This is called the acetabular canal. Then if we see the interior of the acetabulum, it has got two parts, smooth part and rough part. The peripheral part is smooth and its shape is moon shape. So it is called the lunate surface. Smooth lunate moon shape is called the lunate surface of this. And the middle part is rough. And it is filled with a little much of the fat and the fibrous tissue. So this is how we discuss the cup or the acetabulum. It is the head of the femur. It fits and a joint is created that is called the hip joint. So this is how the joint is formed by the two. Now the second heading is the fibrous capsule. So fibrous capsule is made up of the fibrous tissue, collagen fibers, and the fibrous capsule function is that it keeps the two bones together, which form the synovial joint, and it keeps them together in all movements. So its attachments is very important. So anterior attachment. So it has got a circumferential attachment. Circumferential means all around the joint it is attached. Anteriorly, the fibrous capsule is attached to the intertrochanteric line. But posteriorly, it is not attached to the intertrochanteric crest, but it is attached 1 centimeter medial to the intertrochanteric crest. 1 centimeter medial to the intertrochanteric crest. So, some part of the neck is intracapsular and other part of the neck is extracapsular. So that is the intracapsular part and the extracapsular part. So this is the attachment of the anterior, the posterior attachment to the femur, the head, and the neck of the femur. Then on the acetabular side of the hip bone, so it is also circumferential and it is attached a little away from the bony rim of the acetabulum. Bony rim of the acetabulum, a little below it. Below the rim, bony rim is attached, and medially it is attached to the transverse acetabular ligament. So it is having the circumferential attachment, the fibrous capsule on the acetabular side. So that is how we have to write down and make the diagram of the fibrous capsule. So from here it goes to the acetabulum. The synovial membrane of this lies internal to the fibrous capsule, and it is reflected on the neck also, and it is attached to the margin of the hemispherical head. So from the head, the synovial membrane is attached where the neck starts, and then the same synovial membrane is reflected inside surface of the fibrous capsule. So that is the position of the synovial membrane. So if we cut the fibrous capsule of any synovial joint, so this fibrous capsule from outside is rough, but when you cut and reflect it inside out, then we see that inside of the fibrous capsule is shining and it is glistening also, smooth. Why? Because it is covered by the synovial membrane, which lubricates the synovial fluid secreted by it. So that is how it is. Then comes the ligaments of the hip joint. So ligaments of the hip joint, there are two. One is the intracapsular and extracapsular. The intracapsular ligaments one is called labrum, acetabulary, and other is called ligamentum teres, or also called the round ligament of the head of the femur, or round ligament of head of the femur. And third is also the transverse acetabular ligament. So these ligaments, they are inside the hip joint and they give the internal strength to the hip joint, and they are bathing in the synovial fluid. We will take one by one. One is the labrum acetabulary. As the name suggests, labrum means they are like the upper and lower lips. So this labrum acetabulary is made up of the cartilage, fibrocartilage, and it is attached to the bony rim of the free margin of the bony rim of the acetabulum. And at the acetabular notch, where the rim ends, bony rim is absent here, then the same labrum acetabulary becomes transverse acetabular ligament. So transverse acetabular ligament is the part of the labrum acetabulary which flattens and gives the continuity to the labrum acetabulary. So this gap is good. When we cut the labrum acetabulary, it is triangular in shape. The peripheral part is thick, which is attached to the bony rim of the acetabulum cup, while its central part, this part, is thin. So the function of the labrum acetabulary, number one, it slightly deepens the acetabular cup. Acetabulum is already very deep, but still it becomes more deeper when it is attached to the margin of this. And this gap is caused by the transverse acetabular ligament, but still there is a gap is there below, which is called the acetabular canal, through which the structure they go in and out of the acetabulum. Second function is that it grips around the neck of the femur. So it grips over the head of the femur and it acts like the lips over the hemispherical head and prevent its dislocation. As you put the lollipop in your mouth, so lollipop has got two parts. One is the stick, other is the candy part. So when you put the candy part inside, so this candy part is head of the femur, and the stalk of this candy lollipop is the femur, and your lips, they are the labrum acetabular. As you closes your lips over the candy and pull it back, now it is not coming out. Why? Because your lips are gripping around the round candy. Same is here the mechanism. So when the head goes inside, so the labrum acetabular will grip over the head and try to prevent its dislocation. So that is how we exemplify with the lollipop. Then comes the ligamentum teres, or round ligament of the head of the femur, or central ligament of the head of the femur. So as the name suggests, so this ligament is attached to the fovea capitis, and to the other side it is attached to the transverse acetabular ligament. Transverse acetabular ligament. So this ligament is round, so it is called the round ligament of or the ligamentum teres. And this ligament carries in the center a branch of the artery from the obturator artery, which comes and it supplies the head of the, it contributes in the head of the supply, arterial supply of the head of the femur. Then the central artery of the ligament teres, which reaches the head and supplies it. So its function is, it gives the arterial supply to the head. Number two, it prevents the dislocation of the hip joint. So if anything which distracts the head away from the acetabulum, so this ligament keeps the head in touch. So that is the function of central head of the ligamentum teres. So it gives the internal strength to the, and transverse acetabular ligament, as we already told you, that is the part, flattened part of the labrum acetabulary which bridges across the acetabular notch. So this is how we describe the ligaments intrinsic. Now come the extrinsic ligaments of the hip joint, or extracapsular ligament of the hip joint. So they are coming from the three bones of the hip bone. Ilium is called the iliofemoral ligament. From pubis bone it is called the pubofemoral ligament, and from ischium is called the ischiofemoral ligament. So three ligaments, three hip bones, and insertion is on the various parts of the femur. So that is how we describe it. First is the iliofemoral ligament. Now as the name suggests, iliofemoral ligament, it is attached from the ilium bone and then attached to the ischium and attached to the femur. So as we know, this is the acetabulum, and this is the anterior iliac spine, this is the anterior inferior spine. So iliofemoral ligament is attached to the anterior inferior iliac spine. Anterior inferior iliac spine, and it is inverted Y shape. It is inverted Y shape. And inferiorly it is attached to the intertrochanteric line. Attached to the intertrochanteric line. So its upper part is thick and the medial part is also thick. But in between it is thin. So this is how the iliofemoral ligament gives the anterior strength to the fibrous capsule. Then other is secondly pubofemoral. So as the name suggests, so pubofemoral ligament is attached to the iliopubic eminence. Iliopubic eminence is the part where the pubic bone meet with the ilium bone. So there is a slightly raised area, and this is called the iliopubic eminence. So from iliopubic eminence, this is a horizontal ligament. It goes deep to the Y shape iliofemoral ligament. Iliofemoral was from the anterior inferior iliac spine. So it was Y shaped like this. The upper and lower part is attached there, and there is a gap in between. So below this, from iliopubic eminence, this ligament goes, that is the pubofemoral ligament, and is attached to the middle part of the intertrochanteric line. And it fills the gap of the Y-shaped iliofemoral. So that is how the disposition of this ligament, that is the pubofemoral iliopubic eminence, and then it covers the anterior part of the hip joint, and then passes below the iliofemoral ligament and attached to the middle part of the gap left by the iliofemoral ligament. So both these two ligaments, that the ilio and the pubofemoral, they give the anterior so both are present anteriorly. So they give the strength to the anterior part of the fibrous capsule, and they prevent the anterior dislocation. Then third is the ischiofemoral ligament. As the name suggests, the ischiofemoral ligament is attached to the ischium bone, ischial tuberosity, and this ligament is inferiorly placed, and it is attached to the lateral part of the ischial tuberosity, and then this ligament is almost horizontal, prevents the inferior dislocation of the hip joint. It goes posteriorly and it is attached to the intertrochanteric crest. So it is posteriorly and inferiorly in relation to the hip joint and prevent the inferior dislocation. So this is how we do the three ligaments and their mutual attachments. Now comes the movements. So movements of the hip joint, they are, number one, this is the flexion, and opposite the flexion, this is the extension. Then this is the adduction, and away from, this is the abduction, and this is the medial rotation, and this is the lateral rotation, and when we move the round, this is called the circumduction. So these movements are possible almost in all ranges. That is called the movements of the hip joint. But which muscles they bring about these movements, that is very important. So we have to make a list of which muscles they bring the different movements. So that is the most important part. So regarding the movements, first is the flexion. So flexion movement is produced by the psoas major and iliacus, and also by the sartorius and pectineus. So all these bring the upward movement of the femur, that is called the flexion. Then come the extensors. All hamstring muscles, they bring the extension at the hip joint. So all semimembranous, semitendinosus, biceps, all they are bringing the extensor at the hip joint. Then comes the adduction. All adductor longus, adductor magnus, adductor brevis, even gracilis, they also form the adduction, and is some extent pectineus also. Then comes the abduction. So abduction is done by the gluteus maximus. Gluteus medius and minimus also contribute in the abduction movement of the hip joint. Then comes the medial rotators. In the medial rotation is bring about the pectineus. Obturators, internus and externus, they also bring the medial rotation. Then comes the lateral rotation. Lateral rotators, they are all the muscles under the cover of the gluteus maximus. We have done starting from piriformis, superior gemellus, inferior gemellus, and quadratus femoris muscle. Quadratus femoris muscle. So they are all the lateral rotators. So this is how we do. Then the blood supply and nerve supply of this, like knee joint, they are also having a very good weight bearing joint. So good blood supply is there. So various arteries, they are present around the hip joint, which gives the artery supply. The various arteries, they are the superior gluteal artery, the inferior gluteal artery from inferior side, then lateral circumflex femoral artery, its transverse branch, the medial circumflex femoral artery is also given the branch, then the perforating branch of the first perforating branch of the arteria profunda femoris. They also forms a good anastomosis in the trochanteric fossa, is also called the trochanteric anastomosis. trochanteric anastomosis. So various arteries they contribute in the formation of this cruciform or the cruciate anastomosis and the trochanteric fossa. And these arteries they also supply the head of the femur and the neck of the femur also. Regarding its nerve supply, as we have already told, articular branch of the obturator nerve passing through the obturator canal and then passing through the acetabular canal, because both are very near. So this is the acetabular canal, and here whole of the acetabular, this obturator foramen is closed by the obturator membrane except superolaterally here. A gap is there, that is called the obturator canal, through which passes the obturator nerve, obturator artery as well as the obturator vein. So as the obturator artery is going down, nerve is going down to supply the medial compartment muscle, so a small branch enters into the obturator canal and will supply the joint. So that is called the articular branch. Now last part comes the applied anatomy of the hip joint. In the applied anatomy, first we will do the hip joint. Is the fracture neck of the femur, which is very common. It is more common in the females above the age of the 60 years. So it is an old granny fracture. So there is a history of fall either in the bathroom or just rising from the bed. So they just slip because of the menopause, osteoporosis, weakness, everything contributes into their fracture. And fracture of the neck of the femur occurs, and it is of two types. This is the neck. Either this fracture is intracapsular, just medial to the attachment of the fibrous capsule, or it is extracapsular, depending upon this fracture line goes in the attachment of this fibrous capsule. So if the fracture line is inside the fibrous capsule, it is the intracapsular fracture of the neck of the femur. If it is here, it is called the extracapsular. Treatment of both these is different. If there is an intracapsular fracture of the neck of the femur, then the arterial supply and nerve supply to the head of the femur is almost cut off. Is almost cut off. Then this head has to be removed. We remove the head in the intracapsular fracture. Intracapsular and extracapsular fracture. In the intracapsular, we remove the head of the femur. And in the market, an artificial steel head is available. And we throw this head and we fit the steel one. This is called the Austin Moore prosthesis. This is the Austin Moore prosthesis. That is the head of the femur is available in the market. So we fit it and patient leads a normal life. If the fracture is extracapsular, then still the head and the neck arterial supply and venous drainage is viable and it is intact. So in the extracapsular, we have not to remove the head of the femur because it is very much attached, fibrous capsule is very much attached to the neck of the femur. So in this case, surgery is done and we put a nail inside from the greater trochanter, a stainless steel nail is put inside the neck and the head of this femur. So we fix the neck with the greater trochanter. And this nail outside is fixed by a plate with screws, and we fit here. This nail is also fitted here, and the accessory nails which fix them with the shaft of the femur is also done. So this operation is called the nailing and plating. Nailing and plating. So this is the method to fix the neck with the shaft and the greater trochanter. If a patient is unfit for surgery, if it is 80 plus or 90 plus age is there, then this major operation is very risky in this age group, because major vessels, they are broken down, and that may lead to the fat embolism, and it lead to the pulmonary embolism and the death. So in this case, we don't disturb the fracture site, and we put the skeletal traction to the lower limb. So skeletal traction is done by pushing a Steinman pin in the upper end of the shaft of the tibia, and we put some weight, which is 1/10 of the weight of the human patient, for at least 2 months, and it may lead to the union. So patient has to remain for 2 months on the bed, and union takes place in 8 weeks, but its drawback is that the lower limb is shortened because of the overlapping of the fractured femur. But in these two cases which are surgical, the length of the lower limb is maintained. So that is the difference. The second applied related to the hip joint is the dislocation. So dislocation of the hip joint is also possible. No doubt it is a very strong ball and socket joint, but still the dislocation is there. Anterior dislocation is not possible because of the presence of the two strong ligaments. Inferior dislocation is also not possible because of the ischiofemoral ligament. Superior dislocation is not possible because of the acetabulum, the cup. The fracture of the acetabulum only can lead to the superior. Only dislocation which is possible is the posterior dislocation, because we have seen that posteriorly there is no any ligament. Only a thin fibrous capsule is covering the joints, so posterior dislocation is there. And after the dislocation, posteriorly, then this head of the femur will go up like this under the gluteus muscles. And because of the overlapping, the lower limb is shortened because femur goes up. So lower limb is shortened. So that is how we diagnose the shortening of the and limitation of the movements at the hip joint will give the diagnosis of the posterior dislocation. Posterior dislocation is there. Then another relationship with the femur hip joint is the avascular necrosis of the head of the femur. Avascular necrosis is also called Perthes disease. Perthes disease. Usually it is common in the male. Around the age of the 13 years, a patient comes with the dislocation, recurrent dislocation of the hip joint, and we take the X-ray. then we see the head of the size of the head of the femur is very small. And cup is bigger, so dislocation is possible. And it is caused due to the tear of the ligamentum teres, which also supplies the arterial supply to the head of the femur. So because of the chopping of the arterial supply of the head of the femur with the tear of the round ligament of uterus, there is a avascular necrosis of the head of femur starts. And that is called the shortening and small size head, and the dislocation is there. So these are the affections of the most common of the hip joint. So we finish with this.